Dr. Smita, are we online and can you start?
Yes, sir, you can start.
So good morning, everyone. And I welcome to this edition of our webinars. I welcome you all today because we are going to have an webinar which is different from what we used to have. Usually we used to have webinars for our healthcare workers, neurologists, students, and we discuss the scientific aspect of the diseases of the particularly neurology and dementia. But today we are dedicating this webinar for the patients and the caregivers, keeping in mind that they are the important stakeholder for the management of dementia. While we manage the patients, we deal with the patients in our clinics, they come as an important stakeholder because whatever we do at their home or at their workplace, it is the caregiver who is to guide them and lead them to live a healthier life, a workable life. So today the webinar is dedicated primarily to this aspect. And as you know, the September is the month of Alzheimer's month, is observed throughout the world. But it is not only a particular month or a particular day. Every day, the dementia patients, they come with their sufferings, and we need to pay them as much importance as we do to our other patients, but they need more and more care. So for this, we have used this webinar to disseminate the knowledge which we are having at the moment about the disease and the sufferings and how to deal with them. So I invite my colleague, Dr. Fahim, to introduce the rest of the part and also introduce our first speaker, Dr. Sinjan Ghosh. Dr. Fahim, please.
Thank you very much, Atanu sir, for the background of the webinar, and a very good morning, everyone, and a warm welcome for today's webinar. At the outset, I thank the office bearers of IN, especially Dr. Sangeeta ma'am, who is with us today, for graciously taking her time to join us and participate in this webinar. We are grateful, ma'am, for your presence here. So as we continue on our journey to demystify dementia, as Atanu sir mentioned, the idea of today's webinar is to raise awareness among the caregivers and patients, addressing the knowledge gaps and working to eliminate the stigma surrounding dementia. As Atanu sir mentioned, every year September is celebrated as the World Alzheimer's Month, and 21st September is the World Alzheimer's Day. Every year, there's a global organization called Alzheimer's Disease International, which is working in partnership with the WHO. They release a World Alzheimer's report. And this year, they have again released the report 2024. And the theme of this report is attitudes towards dementia. And there are many highlights in that. And the key highlight this year they have found, basically, it's a report that represents a global survey of 70,000 participants across 155 countries. And the key highlight they mentioned is 80% of the general public believe that dementia is a normal part of aging. This is compared to 66% in the year 2019. So there's a dramatic increase in the unawareness among the general public. And 65% of the healthcare professionals, they share the same belief. This is compared to 62% in 2019. So again, among the healthcare professionals also, there's a rise in unawareness. So these figures, they reflect the growing... Yes, ma'am. Yeah.
I said we have to work hard then.
Yeah.
Yes.
So these figures, they reflect a misconception about dementia over the last 5 years. So a rise in unawareness, and that's why underscoring the urgency of initiatives like today's webinar. That's why all of us are here. And I'm very happy. Many of our caregivers have joined across the country, and that is so heartening to see. And I request them, please feel free to put your questions in the Q&A box, because after the talk, we'll have a panel discussion and we'll take up your questions during that session. So without further delay, it's my pleasure to introduce the speaker for today's talk, on demystifying dementia by my friend Dr. Sinjan Ghosh, who brings an invaluable expertise and insights to lead this important topic. So, Dr. Sinjan, after completing his neurology training in Kolkata, he pursued a clinical fellowship in cognitive and behavioral neurology from the University of Toronto, Canada. He has multiple scientific publications, national, international, peer-reviewed journals to his name. He's an executive board member of Alzheimer's and Related Disorders Society of India, Kolkata chapter. And then he's a part of Kolkata Neurology Association, Indian Academy of Neurology, Cognitive Neurology Subsection, and also part of the AI research and education in University of Toronto in Canada. He actively participates in public awareness initiatives. His present endeavors are related to establishing collaboration with multiple academic institutes for translation research and advancing artificial intelligence in dementia and other neurodegenerative conditions. Apart from this, he is a very kind, empathetic human being. Over to you, Sinjan, for the talk. The stage is yours.
Thank you very much, Fahim, for your kind introduction. Thank you very much, Atanu sir. And at the outset, I would like to thank Sangeeta ma'am and the Indian Academy of Neurology and members of the Cognitive Neurology subsection to invite me for this presentation. And it's a wonderful initiative to raise dementia awareness in caregivers. So I would like to share my screen now. And I hope I'm audible.
Yes, yes, please.
Yeah. Okay. So my focus of today's talk would be to try and demystify dementia, followed by panel discussion by esteemed panelists. So in the next few minutes, I'm going to talk about what dementia is, what are the types of dementia, what are the common symptoms of dementia, the causes and risk factors, and how we can mitigate those risk factors and prevent the progression of dementia. And also there are certain reversible dementias that we should be cognizant of. And how do we diagnose dementia, and then the concluding remarks. So before we delve into dementia, we need to understand how our memory is stored and how it works. So for example, if you go out for a walk in the morning, so with our senses, we perceive our environment, right? Birds chirping, rustling leaves, people laughing, talking. We see buildings, trees, and cars honking. So these are a part of sensory memory that we perceive through our senses, but not necessarily we do remember all these, right? So, for example, if we meet a long lost friend, suddenly our attention is focused there and we talk with them, we share our memories, and that is when it is stored into our short term memory. We come back, we discuss with our family members, and we remember our encounter. So what happens is that when we go on rehearsing a thing again and again, we recall, we reminisce, then a short term memory is transformed into a long term memory. Our brain realizes that this is something important and we need to store into our long term memory, which is more resilient, which is more strong. Now, I would like to give you another example. So the analogy is of a pen drive and a laptop, right? So if we consider that we've stored some data and files in a pen drive, so that is what short-term memory is all about. So whenever we have to access that data or information, we need to go searching for the pen drive, we need to connect it with the laptop, and then we can access the data. So every time we access our short-term memory, we consciously go try and recall the events. So now some of the information. So brain has this incredible filtering mechanism. It filters out unnecessary information, which are deemed not necessary for our day-to-day life. So eventually we forget those memories. So I'll give you an example. If I ask you, what were you doing last year on the 16th day of July? Many of us won't be able to say because it was an ordinary day for most of us, a mundane day. So we didn't remember. But does that mean we have memory problems, cognitive problems, or dementia? No, because we've filtered out that information. But if somebody had a birthday on that day, or an anniversary, or it was their graduation day, then they would remember the events from that day. So that is a red letter day for them. So that is when those events and episodes are transformed into long-term memory. And also another important part, as I mentioned, that before exam we rehearse, we read and write, we retain those information in the long-term memory. So that is, we copy our information from the pen drive to a laptop. So whenever we go and open the laptop, we have that information right there. Now, coming to what dementia is. So it is an umbrella term where there's a impairment in memory, thinking ability, severe enough to hinder day-to-day activities. There are many different types of dementia as well. So usually they have a gradual onset. They come slowly and they eventually get worse day by day. And they, to that extent, that they start affecting the day-to-day life or functioning. But there are some types of dementia which can be rapidly progressive. They progress rapidly and relentlessly. So there's a subset. So it should also be a condition which is not explained by other reversible causes, which I'm going to discuss later, such as vitamin deficiencies, depression, or anxiety. Now, many a times I've heard patients and their caregivers asking, Doctor, do I have dementia or Alzheimer's disease? So it is very important to understand what these two terms signify. So as I mentioned, dementia is an umbrella term, and Alzheimer's disease is a commonest type of dementia. In dementia, the age of onset depends on the type of dementia. So some dementia can occur at a very early age, and Alzheimer's disease is usually seen after 65 years of age, but we do have some patients who have early onset, that is, in their 40s or 50s, they might develop symptoms. And some reversible causes, which we'll discuss later, can also produce dementia, but Alzheimer's disease is a condition which is progressive. It can be slow, it can be fast, but it eventually progresses. Now, coming to the common symptoms of dementia. So there are different faculties or aspects of the brain which are known as cognitive domains, which help us in our day-to-day functioning. So to remember, we have this mnemonic, which is known as visual realms. So visual, that stands for visuospatial, basically. Recall, executive function, attention or focus, language, motor or praxis, and social cognition. So I'll discuss these in details. So what is visuospatial? In simpler words, it is basically our GPS or global positioning system of our brain. So it helps us in navigating through our external space under visual guidance. So people or individuals who are having problem with visuospatial function, they have difficulty finding their way back home. They get lost in the local market. There are instances where people have wandered away from their home and found 2 days later or weeks later as well. They have difficulty in finding the bathroom inside their house as well in advanced stages. Now, recall or memory. So basically forgetting events or conversations. We see patients who have these complaints. They tend to ask repeated questions. They have difficulty recalling names, and they misplace objects as well, where they have kept their mobile phones, where they've kept their glasses, and they sometimes forget to turn off the stove or a running tap. Now, coming to executive problems. So what are executive functions? Basically, we plan an action and we think of the steps, and then we do the work, we execute the work. So if there's a problem with that area of the brain which is responsible for this, individuals can have executive problems. So they can get easily frustrated. These are some of the manifestations or symptoms that you as caregivers can pick up. So they have inability to complete a task. So there's a change from what they used to do, what they were capable of doing, and now they are unable to. So they have struggle with multiple step directions. So somebody who used to cook well has problems with cooking. So they can have poor self-motivation, trouble organizing or staying on schedule, and difficulty in problem solving as well. Now, as I just discussed, attention or focus is extremely important because we need to be attentive to register an information so that we can recall later. Until and unless we are attentive, we will tend to forget things. So individuals who have problems with their attention or focus, they many times lose track while having a conversation. So somebody has to tell them, okay, we were talking about this. So they have to flip back a few pages of a novel to remember the storyline. They have to rewind or ask about the context and plot while watching a movie. Now, coming to the language aspect, some people forget names. They have difficulty in finding the right word. So they know what to say, but they can't just find the right word. They have a problem with their speech. They can have difficulty in reading or writing, and they can have poor understanding of the meaning of a spoken or written words. Another aspect is also known as praxis. So in simpler terms, praxis is the formula or the formulas which are stored in our brain that are learned over the years. So how we talk, how we walk, how we use an instrument, how we play a guitar, things like that. So if there's a problem in that part of the brain which is responsible for praxis and which stores these formulas that we retrieve and use while we do an activity, so that is when people have problems with praxis. So it is basically the ability to conceive or organize and carry out or execute a motor action. They might have clumsiness while doing a work. They might select wrong tools or instruments for a specific task, like using a screwdriver instead of a hammer when a hammer is required. And they might have difficulty in carrying out very simple tasks like brushing teeth, cutting vegetables, etc. Now, coming to social cognition. So sometimes we see elderly individuals develop lack of feelings or empathy for others. They have socially inappropriate behaviors or speech. They can have sexually explicit actions or gestures, which is embarrassing for the family members as well. They might have difficulty in catching subtle sarcasm. They might take things literally as they are being said. Now, coming to the activities of daily living. So, as I mentioned, when these brain faculties or aspects of the brain functioning are affected to that extent that the activities of daily living get affected, that is when we term it as dementia. So there are instrumental activities of daily living, which are basically complex tasks that may not be essential for functional living, but improves one's quality of life and ability to live independent, such as managing finances, cooking, housekeeping, and using transportation. So when instrumental activities of daily living start getting affected, so their professional life get hampered. And sometimes people have to leave their job just because of these problems. And eventually, when the dementia advances, even the basic activities of daily living are also affected, such as mobility, feeding, toileting, dressing, washing, or transferring. And they get dependent on their caregivers. Now, key points that we look for in an individual who is having some cognitive problems or problems with their brain functioning. So we look at the different aspects of the brain, as I mentioned. What is the extent of involvement? And is it severe enough to affect their functionality? We also take into consideration the psychiatric symptoms, because psychiatric symptoms can affect the brain functioning as well. And if those are the sole, like depression or anxiety, if they are solely responsible for the cognitive problems, treating them can make things better for an individual having those problems. Now, in dementia, advanced stages, there can be certain behavioral problems. People can get agitated, they can get angry, they can get aggressive. So we need to take care of these behavioral changes and how we can reduce these symptoms so that there's a reduction in caregiver stress and burden as well. And coming to the physical part, so this was the mental and the brain aspect. So what happens is that eventually they refuse to take food, they refuse to take medications, They refuse to go to sleep. So eventually, their physical health declines as well. They reduce. There's a weight reduction, and there's a problem in their immunity as well. So the important aspect is to discuss with the caregivers and family members and try to sort out these complex set of problems into a more understandable aspects of cognition, and we try to deal with them, we try to treat them accordingly. Now, coming to the types of dementia, um, apart from Alzheimer's disease, there are other types of dementia which we get in our day-to-day practice, such as vascular dementia, dementia with Lewy bodies, mixed dementia, frontotemporal dementia, and Parkinson's disease with dementia. There are other rarer dementias as well, but I'll focus on mostly the common dementia types. So Alzheimer's, as we've discussed, it is the most common type of dementia. It is named after this gentleman. He is Dr. Aloy Alzheimer. He was a physician, and he saw the first patient who had symptoms, which were later diagnosed to be a condition which was termed as Alzheimer's disease. There is still no cure yet, but temporarily we can slow down the symptoms and improve the quality of life of individuals with dementia if it is detected at a very, very early stage. Now, if we look at the picture A, so this is how the units of the nervous system, that is the neurons, these are cells in the brain, so they look like in normal individuals. So in the figure B, this is what an Alzheimer's brain looks like. So there are protein depositions, which are known as amyloid plaques, and neurofibrillary tangles. So what happens is that there's impaired clearance of these proteins, which eventually triggers shrinkage of the brain. So as we can see in the figure C, one half shows the healthy brain and the other half shows a brain of severe Alzheimer's disease patient. So as we can see and fathom that there's severe atrophy, and evidently there would be some gross functional impairment as well. So Alzheimer's, we have to keep in mind, is not normal aging. Sometimes individuals ignore the memory problem, saying that, oh, it's part of aging. But we need to be careful that we should consult a physician as to whether this memory problem or other cognitive problems are severe enough to be termed as Alzheimer's or not. They can sometimes strike at a very young age. So we need to be careful. We need to make our lifestyle choices at a very early age. And Alzheimer's may be in your genes that can be genetically inherited as well. And the main villain out here is the ApoE4 gene, which has been diagnosed. So this was a riddle that I wrote for my students many years back. So here it goes. That day I had breakfast twice. I felt so full. I lost my way to the market. I felt awful. My wife found my pair of glasses inside the fridge. It's kind of strange. That day I gave someone a 500 rupee note and didn't bring the change. But flashes of memories are vivid from the past. My childhood friends, forgotten lanes, my first crush, and the rainy window panes. So what do we see here? This is a life story of an individual suffering from Alzheimer's disease. So the first part, having breakfast twice, he has forgotten that he had breakfast. So that is a short-term or episodic memory problem. Losing the way to the market, as I mentioned, that is problem with their GPS of the brain or the visuospatial function. Misplacing objects like putting glasses in the refrigerator and difficulty in and forgetting to bring the change back home. But in the earlier stages, there can be relative sparing of the long-term memories. They can remember things from the past, but they'll forget what they had for breakfast. Now coming to the vascular dementia, the brain has intricate network of blood vessels which supply oxygen and nutrition. So when somebody has a stroke, one or many of these blood vessels may be blocked or may start bleeding, which can lead to damage to a specific area of the brain. So what happens is that they have problems with orientation, they lack judgment, They might have difficulty in speech and communication and also visual loss. So it would depend, the symptoms would depend upon which area of the brain is affected. So this is one of the dementias which can be prevented if we maintain a good lifestyle choice. So like quitting smoking, alcohol, exercising regularly, controlling the blood pressure, cholesterol, and managing the weight. Now coming to another type of dementia, which gets its name from Lewy bodies, which are clusters of abnormal proteins which get deposited inside the cell and in our brain, and then they result in shrinkage of the brain. And what happens is that they have a steady decline in their thinking ability, they have memory loss, they can have visual hallucination at a very early stage. So, Alzheimer's disease patients have visual hallucinations at later stages, but dementia with Lewy bodies, this dementia can have hallucination from a very early stage as well. So, what are hallucinations? They are basically seeing things, animals, or people who are not actually present. What are delusions? Imagining things and nurturing false beliefs as truth. So they might say that somebody is trying to harm them, somebody is going to kill their family members, and scary thoughts, which are not actually true. So they can have problems with their posture, walking problems, which represent what we know as Parkinsonism. And they also can, their partners can tell us that they have a problem in talking in their sleep, moving, punching in their sleep, as if like they're acting out their dreams. And also they can have dizziness and drop in blood pressure. So the important points to remember are these are movement problems. They can have dementia. So they usually present simultaneously or within 1 year of each other. And DLB symptoms worsen over time and shorten the lifespan, unfortunately. Now, coming to mixed dementia, it is basically a coexistence of different types of dementia. For example, both brain blocks like vascular dementia and amyloid plaques like Alzheimer's disease can be present together, or occurrence of amyloid protein along with Lewy bodies, such as seen in dementia with Lewy bodies, they can present together. And based on the varying mix of the pathology in their brain, they can have different manifestation, as we discussed. Now we come to a condition known as frontotemporal dementia. So in the recent times, we've heard about a very famous Hollywood actor who is suffering from this condition. So this type of dementia gets its name from two regions or parts of the brain, which is known as the frontal lobe and the temporal lobe. So basically, that is why it is known as frontotemporal dementia. So for simplification, frontal lobe is the region of the brain just behind our forehead, and temporal lobe is the region of our brain just behind our ears, in between our ears. So the functions of the frontal lobe are basically planning, judgment, decision making, social skills, personality, and motivation. Whereas in temporal lobe, predominantly language, memory problems, and some behaviors as well. So when these two regions of the brain are affected, we expect to see that patients would have a loss of filter. That is what family members tell us. So they have a lack of filter, almost childlike. So that they lack respect for others, impulsive actions and behaviors, loss of motivation, social isolation, and trouble reading the emotions of others. They have repetitive speech or actions, and they have increased preference for sweets, and they tend to overeat. So when these symptoms are seen, we think of frontotemporal dementia, which can be inherited genetically. They can have individuals and family members who have these problems. Now coming to Parkinson's disease with dementia, it is a condition you might have heard about this. There's a chemical called dopamine, which is responsible for our motor actions, that is our movement of our body. And also, this is what keeps us happy. So when evidently this dopamine levels start dropping, the movements become slower and clumsy, and also people have low mood. Now, they can have speech difficulty, slowness of movement, as I mentioned, unsteady balance, and decreased facial expression. They can have swallowing problems and they can have walking problems leading to falls. Also, they can have tremors in their hands. But mind it, every tremor is not due to Parkinson's disease. You need to discuss with your clinician, your physician, to understand whether it is Parkinson's disease or not. Now, there's another form of dementia which we get in our day to day practice, which is known as normal pressure hydrocephalus. So, this is one of the reversible causes of dementia. I'll discuss how. So, as the name implies, hydro means water and cephalus means the brain. So, basically, there's excess water accumulation in the brain. So, the cerebrospinal fluid, as you can see in the image on the right hand side, it helps in cushioning. It acts as a buffer and protects when we have a trauma to our head. It protects the brain from mechanical shocks. So, whenever that fluid is in excess, it starts affecting the brain and they develop these symptoms. There's a decline in thinking and logical ability, change in walking and posture. They have a mood, personality, and behavior changes, and loss of bladder control. They can't hold their urine. So, the good thing about this condition is when detected early, in some of the individuals, after doing a procedure which is known as shunting, that is, we drain the excess fluid from the brain to our tummy or abdomen. And then the symptoms start improving. This is something which should be identified so that we can offer a better quality of life for the patients. Now, coming to the risk factors, which is very important. So, in 2020, the Lancet Commission, which is a very well accepted and renowned journal, they have come up with, their group have come up with 12 risk factors of dementia, such as diabetes, hearing loss. As we see, many elderly individuals have hearing loss, but they do not use hearing aid due to multiple reasons, due to cost factors, due to stigma. But it is to be remembered that hearing loss can trigger cognitive problems and dementia. So that is why we need to treat it. So high blood pressure, air pollution, excessive alcohol consumption, and depression, as I mentioned, can result in cognitive changes, head injury, social isolation, obesity, and less physical activity, or smoking and less education can be other risk factors as well. Now in 2024, this is the most recent one, the Lancet Commission, they came up with two other risk factors, which are high LDL cholesterol, which is also known as the bad cholesterol levels, and visual loss. So these are risk factors which we can modify. So one is nature, what we inherit from our parents, and one is nurture. What is our life story? What are our lifestyle choices? Whether we can reduce these risk factors from a very early age, in our 30s or 40s, we have to be extremely careful to reduce these risk factors. So 45%, that's a significant amount, we can modify and reduce the chances of dementia. Now, how do we prevent and reduce the risk? So controlling high blood pressure, sleeping well. We shouldn't take pride in saying that we sleep 3 or 4 hours a day and that's enough for us. You are damaging your brain. So we need optimum amount of sleep, 6 to 8 hours, to strengthen our memory, what we've learned throughout the day. So as I mentioned, transformation of short-term memory to long-term memory, and placing things in order, just like in the library, so that we can pick out a memory when required. So eating a healthy diet, keeping physically active, it has been proven in studies, not only it is good for physical health, it is good for our mental health, mood, and memory problems as well. It can help increase focus. And connecting with family and friends. After the pandemic, we've noted that many of our relatives, friends, even us, we had problems in focus and attention as well. We couldn't connect with friends, we were in lockdown, and things got worse for many people living with cognitive problems. Now, I would like to reiterate that challenging the brain every now and then helps. So you learn a new language, you learn a new musical instrument, puzzles, crosswords, sudokus, those help. And also uh, be a learner or student for life. That helps your brain. Now, these are the diet for Alzheimer's disease, rich in vegetables, fruits, and omega-3 fatty acids, which are found in fish, and a balanced diet. And we should cut down sugar levels as well in our diet. Now, coming to the reversible dementias. So we can remember the causes from dementia itself. So D stands for drugs and delirium. If somebody uses the conventional sleep medications for a long period of time, they can have problems with their memory. Not only memory, but their walking as well. And then something known as delirium. This is a condition in acute phases, in acute infection, when patients are in ICUs, they can have this condition. They have difficulty in recognizing people, friends, and family, memory problems, and it seems that they are having dementia. But many times, after treating the acute condition, they get better. But we should also keep in mind that people who have dementia are more prone to develop delirium after, say, a surgery or an acute infection. Now, E for eyes and ears, if we have hearing difficulty or visual impairment, as I mentioned, they can result in dementia. Metabolic causes such as vitamin deficiency, vitamin B12, which is very important for our brain, vitamin D, which is also important, depression, anxiety, normal pressure hydrocephalus, as I just discussed, tumor or trauma to the brain, infection. If we treat the infection, things can get better, and autoimmune conditions. What happens in autoimmune conditions? The antibodies are developed inside our body, and instead of targeting a foreign virus or bacteria, it starts affecting the brain as well. So that is when people develop features suggestive of dementia. And if we treat that, many patients can get better. So how do we diagnose dementia? So there are barriers, so both for people living with dementias as well as clinicians. Uh, so that is the sole purpose of this type of meetings. So we need to raise awareness so that there's a dearth of information we need to discuss together and bridge the gap. There's a stigma that whether we should share with our friends or family or not, and lack of access to healthcare. And for clinicians, lack of diagnostic support in many of the centers, especially in rural setting. And another important thing I would like to highlight is professional nihilism. That is, what is the point if we don't have a cure? But I would like to say that in last few years, things have changed and we can help the patients and their families with our support system, our full medical multidisciplinary team. So there are memory tests, which are pencil and paper tests to diagnose your condition. There are blood works to rule out reversible causes of dementia as well, whether you're having vitamin deficiency. There are markers which can say whether you are prone to develop dementia or not. And also brain studies such as scans, CT scans, and MRI or EEG. So this is a pencil and paper test, which is a very common MOCA or Montreal Cognitive Assessment, which is done in clinics. Now, the concluding remarks. So we need to learn more about dementia, support individuals and families affected with dementia, advocate for awareness and funding for research. And as I mentioned, 45% of dementia is attributable to modifiable risk factors. We need to target that. Despite there being no curative treatments yet, there are interventions that can improve quality of life for persons living with dementia and their caregivers. And before I end, I would like to quote this from a very famous movie, Shawshank Redemption. The protagonist mentions that hope is a good thing, maybe the best of the good things, and no good thing ever dies. So in search of silver linings and light at the end of the tunnel. Thank you very much. I would like to especially thank all the caregivers and the family members for being so resilient and being steady in the face of adversities. Thank you so much.
Thank you very much, Dr. Sinjan, for that lucid, wonderful presentation in demystifying dementia. So I think we can, in view of time, we can further go on to our next session. Dr. Atanu, sir, maybe you could proceed.
Yes. Thanks, John, for a lucid description of what is the knowledge about the normal aging and dementia and what are the aspects of different types of dementia and what are the risk factors. We have dealt with everything and in a very lucid manner. I think this is understandable even for lay persons and which are our target audience today. Now, I would like to introduce our next session and the panel discussion. We are fortunate to have our Indian Academy of Neurology President, Dr. Sangeeta Rawat. She is currently the Dean and Professor of the Department of Neurology at SAIT's GSMC Medical College and the King's Edward Memorial Hospital at Mumbai. She is an epidemiologist, is a renowned clinician and a very well-known teacher in medical college. And we are fortunate to have you, madam. I welcome you to be a panelist of this important session of caregiver and for patients of dementia. Our next panelist is Dr. Amitabh Ghosh, who is my senior and a mentor of many of the cognitive neurologists in this country. He was the first person to introduce cognitive neurology in the country, and he's now the director of neurology at Apollo Multi-Speciality Hospital in Kolkata. He had conducted several researches, particularly on the frontotemporal dementia and various kinds of behavioral problems that are seen, especially in this country. What are the differences of the behavioral symptom from the Western countries? He had multiple publications in highly reputed journals. I welcome Amitabh for this panel discussion. Our third panelist is Dr. Priya Thomas. She is a psychiatric social worker now working in the National Institute of Mental Health and Neurosciences. She holds PhD degree and she has been doing a tremendous job in particularly managing the patients of dementia as well as psychiatric illnesses and helping the caregivers to deal with this problem. She is a Commonwealth Scholar India for her dementia studies program and undertakes qualitative research with the group that she is working with. She has published and contributed 86 journal articles and book chapters in her subject area, and she has been involved in several research projects in her institute as well as with collaboration with other institutes. Our fourth panelist is Miss Sadia Hujjuk. She is now attached with as a program manager and psychologist at the ARDSI Hyderabad Deccan chapter, and she has been involved in various research works, particularly the most important one is STRIDE, in which she was working with other institutes like NIMHANS and ARDSI other chapters. She is a psychologist and she studied in the University of Stirling. She has over 8 years of experience of dementia professional working in various different setups in like hospital, daycare, as well as memory clinics. She is involved in various research studies on topics such as person-centered approaches in dementia care, benefits of cognitive stimulating activities in people living with dementia, etc. She has a vast experience of managing patients and caring patients with dementia. I welcome Sadia. And also I welcome Srinitha. She is working as occupational therapist in NIMHANS, Bangalore. She is the superintendent of the occupational therapist there, and she is having a skill in implementing personalized therapeutic intervention to enhance patient outcome. She's renowned for integrating advanced technology and innovative techniques into the treatment plans. She has 2 decades of experience of providing occupational therapy for patients living with dementia and other neurocognitive dysfunctions. She has special expertise in pediatric occupational therapy. She's as the panel member, the medical board member of Karnataka state government member and medical board for patients with specific learning disabilities. So I welcome Srinitha and of course our The moderator for the panel discussion is Dr. Otri Chatterjee, who is a cognitive neurologist, who after doing neurology residency at Nilnathon Sarkar Medical College in Kolkata, did his fellowship and behavioral neurology and dementia at University of British Columbia, Canada. She worked as assistant professor in Subsection Hospital and now moved to the Bardhaman Mahavir Medical College and RML Hospital in Delhi. Otri is a very good clinician and a renowned cognitive neurologist, our good friend. I welcome Otri. You now lead the panel discussion and start moving.
Thank you, sir. So, first of all, I must thank IAN for providing us this platform. This is a very important part of our work because availability of information to Indian patients and their caregivers are much less to what is available to Western patients. And our patients do have a lot of questions that need to be answered apart from writing prescriptions. In comparison to many other diseases, I think it takes a dementia diagnosis basically involves the entire family. So, not the primary caregiver, who is often the spouse of the patient, the children, even the grandchildren are involved in the care of the patient. So, that is why I think this effort on part of the cognitive neurology subsection is very important. And I hope, apart from those who are participating in this live, the YouTube videos will be perused by all of our patients for years to come. So, with that brief introduction, I'll start the panel discussion with a cue. So all of our questions today that we are discussing are arranged in forms of scenarios that our patients or their caregivers face. And I understand that a lot of caregivers are online today. So if you feel that any of your queries are not already mentioned in this panel discussion, please feel free to write in the chat box, and we'll try to take up as many questions as possible as we go through this discussion. Now, to start with, madam, the first scenario is where a person comes in and asks the doctor, over the past 1 year, my loved one has gradually withdrawn from his or her usual hobbies. Or she doesn't take care of the garden anymore, doesn't do puja, doesn't read anymore. Can this be the first sign of dementia? Should I go to a psychiatrist or a neurologist, or should I just wait till any further symptoms develop?
Good afternoon, all, and I think really thank Fahim and the whole team of cognitive neurology subsection to arrange this. I think it's very important that we deal and explain the disease to the layman and the caregivers who are dealing with this personally. So now going over to the first question. So I think it is important that you go further down a little bit in the history, whether this is a recent onset or whether it is, over the time it is progressive or it is just static. Secondly, once you know that it is progressive, also see whether it is only in the gardening one hobby or it is also in the multiple things he has start withdrawing in everything. Has he start withdrawing in the social gatherings? Has he start withdrawing in the his day-to-day, supposing his gardening maybe one, but he was going for a walk which he has stopped, he was meeting friends which he has stopped, something like that. If more than one aspect, definitely you have to be careful about it, but also at the same time see if there is any acute stressful event that time, like loss of a spouse, loss of a close friend, or there is a stressful, like the daughter-in-law, son-in-law, someone behaving oddly. So this acute events may cause a pseudo dementia, like they go into depression, and so that also needs to be thought about it. And in the end, if you don't find any of these things are there, but it is progressing and it is occurring into multiple domains, then definitely you must go and seek to the neurologist. If not available, at least go to a geriatric who is looking after, or go to a general physician. So the first symptoms and this thing can be taken more into detail by the physician, and then they will let you know after going into details whether tests are required, whether further blood test for some reversible causes which Shenzhen said that is there, or we need to go for the MRI or for the test.
Thank you, madam. So, apathy being one of the commonest neuropsychiatric symptoms of dementia, I think for the caregivers, it's an important message that if this symptom is progressing and is involving more and more activities, then possibly it's time to go to a doctor rather than ignoring this symptom. So, for the next question, I'll come to Amitabh sir. So, the next scenario is also a very common scenario where the son or the daughter comes to us and asks us that my father is misplacing items around the home. He sometimes forgets to take his medications, and but otherwise he's independent. He can go out for a walk. He can use an ATM card, but it seems that some of the activities that he used to do without any help, now he has started forgetting. So can this be the first sign of dementia, or is this just normal aging?
Age.
And as we have discussed for a while, so should we do something or should we just wait? Uh, Sir, your
You're muted.
computer is muted.
Yeah, okay. Thank you. Thank you. Thank you, everybody. Thanks for inviting me. It's a very common question, you're right. And those who have listened to Dr. Shinjon's talk, he started with something like that, saying, how do you try and differentiate a patient with normal aging versus a patient who is going to progress to something like dementia. So normal aging, everyone at a certain age start forgetting things. And the commonest thing, as you will all recognize, is forgetting names, for example. And that's pretty common. You do sometimes forget things you've done a long time ago. Dr. Shinjon said 16 July last year, what did you do? Those are things you're not supposed to remember. You do forget things here and there. Sometimes you forget words as well. You just have to kind of rack your brains to get the word. But otherwise, you're fully independent and it does not generally progress. So it is more or less in keeping with what other people of your age would be having. And the family isn't worried. You may be concerned about that, but the family said, no, everything is all right. No. So that is a situation which could still be normal aging. Why I say still is because you need to still observe that because many of these patients may eventually, especially those are particularly what we used to call worried well, they may eventually progress to have some other symptoms, but in general, that is normal aging for all practical purposes. If you start forgetting more than that, if you start forgetting more recent things, if you're, even occasionally you're losing way in very familiar places, you're having some difficulty counting. So some of the various cognitive problems which Dr. Shinjon had described, others coming in combination, then I think that would be a red flag. And you should be considering going to a doctor. Remember, none of these necessarily have to be dementia, because for dementia, it has to be far more advanced and you'll have to have functional decline, something that has already been discussed again. But it could be very mild. We call it mild cognitive impairment. And those are the stages which we actually recommend that you should come and visit the doctors, because a lot still can be done at that stage. So, yeah.
So for the caregivers, I guess the message is that mild cognitive impairment is the best time to visit the physician. So if you actually have this question in your mind that is this dementia, then I guess you shouldn't wait anymore. You should go to the doctor and settle the question rather than waiting for full dementia, full-blown features of dementia to appear, which often happens even in educated families in India. So for the next question, I'll again come back to madam. So after the diagnosis has been given, as families often become overwhelmed by this diagnosis of Alzheimer's disease, and because even now the rate of diagnosis is quite low in our country, our patients, they don't know anyone around them who has received a diagnosis of dementia. So the patients or the caregivers feel this is such a rare thing that has happened to me. But is that true? Is it such a rare diagnosis?
No, I think, see, the recent 2023, this thing was there 8.8 million people above 60 years of age have dementia in India. So it is not a rare diagnosis. You don't have to get scared of it. Basically, it's if you have an early diagnosis, it is good so that you can plan your rehab, you can plan your intervention therapies which are there, and also as Sinjan said that it's that we also have some treatment for it, and the whole rehab can be very well planned, the future can be planned, so it's nothing to get scared about it. Often why people don't know about it, because there is a little stigma. So often people say that if my father has got dementia, they don't want to tell others, because there are somewhere people know that maybe in the future I will also get a dementia, they don't want to say that. So that social stigma also keeps them so often your neighbor may be having a dementia, the old man, you may not even know about it. So it's not that it is not uncommon. In fact, now that the more easily we can diagnose with PET scan and detailed neuropsychology testing, more and more people are being diagnosed as dementia, and Alzheimer is one of them. It's there that it is a progressive disorder, I do not deny that, but definitely it is nothing to get so scared about it, but you have to deal with it. You have to prepare yourself, all family members, for that this thing, that whole journey which you're going to have. So it is, don't get scared, accept it and face the challenge. I think that's what I would say.
And just to put that number of 8.8 million or 88 lakh in context, it's comparable and or slightly more than the people, that the patients living with tuberculosis in India. So for a very long time, we had this conception that tuberculosis is our problem, dementia is a Western problem,
Western problem, absolutely.
which is not
But it
true.
is not true.
So
Our
we are just
age
ignoring the
expectancy is
problem.
also increasing now. Our age longevity is also increasing. So that's why we see more and more people with dementia, because it's basically a disease more or less in the elderly.
And I guess, madam, once a patient is diagnosed, the entire family is in for the journey
Absolutely.
for the rest of the
Absolutely.
lifetime for many, many years. So that makes the experience compared to a curable disease, in many cases fatal, but still a curable disease like tuberculosis in context.
Absolutely.
So for the next question, I'll come to Dr. Shinjan. Thank you for your presentation. I guess it will be a very valuable resource for our patients. So my question is, this is also a common scenario that I took my loved one to see a neurologist, and the doctor has made a diagnosis of dementia and has prescribed medications. Now, should I start the medications or should I go for a second opinion? And I feel the symptoms are mild at this point. So should I wait till the symptoms worsen to start the medications?
Right. Thank you very much, Dr. Tri. So this is a very important question, because whenever somebody gets a diagnosis of dementia, which doesn't have a cure yet, it's in the phase of denial that why did it happen to me? Is it really the case or is it something else? So that's when they think of consulting another doctor whether the diagnosis is correct. So it is important to ensure that all the tests that I've mentioned, that all the reversible conditions have been looked into and have been addressed. It is essential, because then we diagnose a person with dementia when the cognitive problems are severe enough to affect that has started affecting the activities of daily living. So it is important to accept the fact and start getting treated accordingly as soon as possible, because a stitch in time saves nine, and you may never know that things can get better eventually, and with medications the progression can be slowed down, and a neuropsychological assessment can be helpful in some cases, because they have a battery of tests where they can delve deeper into the condition and they can confirm a diagnosis of a clinician. Thank you.
And again, I'll come back to Madam. I know Madam has to leave early. So my question to Madam is, so this is a question that we face more from the children, I guess, or from rather than from the patients. But can I reduce my parents? One of my parents have dementia. How can I reduce my risk of developing dementia now that I am into my 50s and I'm also nearing my retirement age?
So I think Shinjan had very good slide on how to preventive factors, some which are naturalistic and some which are genetic. So which we can modify are that like control of your blood pressure or, risk factors which you have, diabetes or, and the, like smoking, alcohol, which can be definitely is in our hands. Secondly, our end is a healthy diet and healthy lifestyle. So your sleep hygiene after 50s is very important. And if you have a obstructive sleep apnea or things like that, a snoring and all, please get it checked with a sleep study, because that itself can also be one of the major risk factors of people think that snoring and all that is very normal. But it is important that if it is in a more than certain amount of your sleep during the night, you will feel drowsy during the day. And then, definitely it is one of the risk factors for, going down cognitively. So that is one aspect, that your risk factors, and this could be this thing. And the healthy diet, I think he has already said more antioxidants and others can be added into it. The other important thing is that you are at 50, so you're not going to retire so soon. But even if you are at 60 or 65 or 70, don't think of retirement of, so you may be retiring from your active job or active thing which you're doing, but you have to keep yourself engaged into either develop a new hobby or develop, he said, like new language learning, new musical instrument. So it is important. The basic line is that you have to keep stimulating your brain. So supposing also people say you play the games. Now you have started playing Sudoku, but you have become expert. So it's no more challenging. Shift over to the new things. So it is important that you continue challenging your brain. And it's not that whole throughout the day you have to keep playing. Play for 15 minutes, but that should also have challenge your mind. So it will increase your cognitive reserve. And this is important that you continue to increase your cognitive reserve. And third thing is that do not, isolate yourself or do not have a loneliness. Continue a social reserve also. So go and meet friends, go for a social gatherings, call people at home, have dinners, go and meet the friends. It is important that you continue doing this. So more and more people you interact, more and more, happiness also you have. So it is important that you also remain happy in your life in the later now. Otherwise, you feel, see, like I have every 31st, I have 15 people who are leaving from my hospital. I tell them the same thing, that life from tomorrow is going to definitely different. You are not going to get up and come to an hospital and go back. But you have to think what you're going to do in next. You may take a whatever bucket list you have. I want to go for this place, that place, go and do those things. So whatever you have missed during your working and productive lives, catch up with all that and continue working in some or the other way. I think that's what I'll say. These are the main preventive factors. No one is a guaranteed fact, but definitely these are useful. And regular exercise. I think physical exercise, yoga, that is very, very important that you continue doing them.
Thank you,
If
madam.
I forgotten, Shinjan can add from his list.
Well said, madam.
So next question, I'll come to Dr. Priya. So this is also this is a particularly social situation that I have faced infrequently, but still there, where the spouse and in my experience, this commonly happens with women patients of dementia, where the husband is unwilling to accept that this forgetfulness or the behavioral symptoms are a result of a organic brain disorder. And I remember at least two families where the children, they have actually read up on the internet, they have talked to me, they have accepted the diagnosis, but the patient's spouse is unwilling to accept that the patient has a problem. And so, how do you go about managing this scenario?
Yeah, thank you very much, Dr. Atri. Thank you, Dr. Athenu, Dr. Fahim, everybody for this, for bringing the caregiving component into this discussion, because it is post-diagnostic support once we diagnose dementia is very important, as has been being discussed. And family is the cornerstone for our dementia care. So when there is a diagnosis of dementia and the spouse is not willing to engage with this process, it can actually be very challenging in ensuring the care plan for the patient. So one thing is, it is important to and also we should realize that relationships are long standing, and when there is a dementia diagnosis, it really doesn't change a pre-existing relationship. So there could be multiple factors that play into a husband's or a engagement with the care process at this point. But then, having said that, it is important that in our post-diagnostic support plan, we make all efforts to ensure that the immediate family, the spouse who will be in the caregiving position at this point, is given an opportunity to process his understanding of dementia that the spouse is going through. Time is given to him and a counseling support, so that there is, whatever struggles that he is going through at this point, to accept the diagnosis is also processed in the counseling session, so that he will engage with this process of a care plan. And as I said, very often we may also have to work with the pre-existing family problems, so that there is some amount of, so ultimately it is important to keep the caregiving, the care of the patient at the center point. So if we can have a family conference and make sure everybody in the family who is in a decision making position there are in the same page with regard to what is expected and what is going to be the involvement, that will definitely help to move forward. I hope.
Thank you, ma'am. So the next question is, I think, has already been touched upon twice, and that is how important this is. That every doctor after diagnosis of dementia talks about being active, right? So we tell our patients that you be active, you do this and that. And this question is to Ms. Renitha. So I think you are also dealing with similar situations. And then the patient, after trying for a couple of weeks or a month, will come back and ask us, so what activity should we do? Right? There are so many things, and yet there may not be as many things to engage in. Right? So, what is your advice to patients, but both for to patients as well as caregivers? So we are trying to impress that be active, don't retire. But what should they do? Right?
Thank you for the question, sir. And good afternoon, everybody. So most of the things what I had in my mind was, again, I have to take Dr. Sinjan's name. He had beautifully explained so many things about IARL, so many things which is affecting the patients, cognitive-wise, behavioral-wise, functional abilities-wise, and all that. So generally, for a normal person itself, being active physically and mentally is very important. Now, for these people, these kind of people, it is more important to be active. So what I have experienced in my department is that whenever you ask any patient, the caregivers, what are you doing? How do you spend the time at home? They would say, no, madam, they forget things most of the time. So it is not possible. So we do the things for them and they put them in a room where they are lying down all the time. So that is the worst part of the thing, that we always ensure that we explain the caregivers more than the patients that how active they have to be physically as well as mentally. So what we used to prescribe them is certain amount of walking, range of motion activities, strengthening activities, balancing activities in terms of physical aspect, and also engage them in meaningful activities at home. Like for example, if it's a female who's having such a problem. So my question to the caregivers, why not engage them in cooking activities? Maybe a simple task, putting a simple tea. Or if you feel the safety is more important, then you'll have to work on their aspects where you label all the parts, or you put them into certain folding activities of the clothes, as normal as they were before, to get them into the track of their normal life. Put them in all the work they were doing earlier also, like they would be doing some budgeting at home, or they would be doing some of the household chores. So which is very important for them to have a meaningful engagement of activities at home, which we emphasize a lot, sir. And apart from this, whenever they feel frustrated or they are feeling low, we always also tell them a trial of there is a New Zealand kind of environment where they can provide where with little of soft musics and a kind of a good lighting environment around the house, or virtually talking to the caregivers. Say, I know in the busy life of all of us, it's so difficult to go to each and every relative's home or the friend's home. So at least arrange virtually where they can talk to the sisters or the loved ones, where they are being active most of the time. Then they also don't feel that they are lonely at home, and that frustration also can be brought down. So these are things that sir, we try. And if there are kids at home, why not play cognitive games like simple puzzles, or identifying objects, matching objects, so that also boosts their energy level better than what they are before. So likewise, in all the aspects, whether it is cognitive, or whether it's functional, or whether it's behavior, as Sijan sir mentioned, uh, these all improve the physical abilities, also the mental abilities. So these are the advices we give for the patient.
So just to add, Srinitya helps all our dementia patients in NIMHANS. She does all the occupation therapy, and what all she mentions, snooze therapy, everything. And majority of the caregivers are feeling much better, and they're giving a very good feedback once they come to us in the follow-ups. Just to add what Srinitya does here for our patients with
I
dementia.
guess we'll need to, we can have a very short segment of a future webinar just on
Yeah.
these activities that can be managed in our homes. Because there are a lot of studies from Western countries which are not possible here, but whatever we can do here and whatever you are already doing, I think it can be disseminated to
Yeah.
both to physicians, neurologists, as well as cognitive neurologists in future. So with that comment, I will move on to my next question, which is to Miss Sadia. So this is a question again from the children usually. So I have tried. I have my one of my parents have been recently diagnosed with dementia, and I've tried reading about dementia, and there is so much information on the internet, and I don't even know where to start and how to start this journey. What are the things that I should plan for at the beginning?
Thank you so much, sir, for the question, and good afternoon, everyone. So this is like, my go-to thing for the caregivers is like once the diagnosis is given, it is like a whole new journey which starts for them. So they have to go through like emotional, physical, financial strain, and then there is a lot that there has to be planning. So as we've been discussing, there is, of course, there is like after the diagnosis, there are counselings that are happening for the family, for understanding what is the dementia diagnosis. And there are a lot of people who are in denial. So generally, it is like, the initial steps as we go after the diagnosis, like in our memory clinic that we run in ARDSI, Hyderabad, that we do counseling where there is like, the entire family or whoever the primary caregiver. So there is a person who takes up the role without like, anybody discussing, and he or she, it could be like any relationship. So they become the guardian, or they become the family caregiver. And most of the time in our country, it is the out of pocket expenditure, at home care. So the family is in a very confused state at that time, and they really need a lot of professional support, as Priya ma'am mentioned, and at NIMHANS, how the counselings are being done. So that's the very primary step. After that, the caregivers need to get into the professional support group which are existing. So there are a lot of these dementia support groups like us that we run, we conduct the monthly caregiver meeting, or we have a WhatsApp group. So the idea behind it is that the caregiver gets as much as dementia information that they can. Internet provides a lot of information, but then it is not like you can just read it can be really very confusing. So after the counseling, they are trained in what are the symptoms, what are the different stages to expect in dementia, what stage will get like what are the challenging symptoms and behaviors, and then how to manage them. So after that, like it is mainly the focus on practical tips, like what can be done at home, and mainly non-pharma interventions, what should be done at home. So ensuring the safety of the patient, building a daily routine with meaningful activities, with cognitive stimulation, functional rehab, so that the patient can retain the independence as much as possible, and understanding the personal care, which is like person-centered holistic approach. so that the person gets the ideal cognitive stimulation, meaningful activities, and tries to have a better quality of life. And then the ideal situation for the caregiver would be like planning for his future. As dementia is very progressive, there are different stages. So, with respect to finance, with respect to what are the services available, what are the professional help that the caregiver can get. So there are like other services like daycare. There are residential cares or even the paid attender services. So the more they understand, they know that, okay, these are the possible things available in the community, in the city, and that helps them to plan the caregiving. So these can be certain steps that, they can, try to identify and understand, which will help for a better quality.
So,
Yeah,
sorry,
and yeah, sorry, just to add it, like when we talk about caregivers, I think there's a lot of expectation from the professionals with the caregivers where we are, constantly trying to tell them, train yourself, learn this. And what we miss out is like their self-care, which is very important. So as I mentioned that the caregiver support meetings, those are the one avenue where they get to vent out, where they get to take care of themselves and de-stress themselves. So, yeah.
and so I just want to just add one particular thing which has become very important in recent years is the prevalence of online scams and financial scams which target elderly people particularly. So I guess apart from what we were discussing, it's important for the family members to look at the safety, whether the patient is able to manage, banking apps or cards, and if you feel that your loved one is unable to manage those things, it's important to keep them out of harm's way because their retirement savings may be at risk. I have faced some similar attempts into in my family, and it's really becoming a menace, and it might be a very a catastrophic thing for an elderly person who is retired, who doesn't understand what is being told to them over phone and getting an OTP or something. So I think that is something that has added to all the established problems of caregiving. This has been an added problem in the past few years. So with that comment, I'll now move on to take some of the online questions. We already have a few. So first of all, I think Dr. Ponda has shared the very detailed case history. So unfortunately, we will not be able to discuss a particular case. I'm very sorry that this is happening in your family, but going through the case, it sounds like it's also sounds like vascular dementia followed by a prolonged delirium. So we'll discuss this bundled with the vascular dementia questions. Moving on to the next question, Ms. Monisha Bora has asked a question that are there any precautionary measures to prevent FTD in the next generation if there is a family history of FTD? So I would request Dr. Chinjon Ghosh to answer this question.
Thank you very much. Very valid question and a concern for the next generation. So, frontotemporal dementia, in many cases, they are genetic, and that is hereditary. They inherit the gene. So, the important difference of frontotemporal dementia with Alzheimer's is that they might not start with memory problems. So, they may have behavioral issues, they can have depression, anxiety, bipolar disorder, and all kinds of psychiatric or mental health issues. So, they might be initially treated as a psychiatric condition. So, things might get delayed and it might get diagnosed, say, 2 or 3 years later. So, it is very difficult to plan their finances and their advanced care planning because frontotemporal dementia deals with like they have problems in planning and organizing. So that's what you need to take care of. If somebody has a late onset psychiatric condition, you need to think of this condition. You need to discuss with your doctor whether you can address those risk factors that I mentioned. You can mitigate those risk factors. If there's a gene, it may not always be that the gene manifests as a disease in all the cases. Whether you would want to know whether there's a gene in your loved one or not, that would be your decision, but there are genetic counselors as well. But I guess mitigating risks and addressing psychiatric conditions, whether they are degenerative conditions such as frontotemporal dementia or not, is essential.
And I think now the genetic testing is also much more widely available, and genetic counseling is also available. So if there is a doubt, then I think not for the person who is asymptomatic, but for the symptomatic person, you can always go ahead and you do genetic testing. So next is a question regarding vascular dementia.
Doctor, can I add something to the previous question?
Sure, sir.
Yes, the question related to if someone knows that his parents are having frontotemporal dementia and carrying a genetic mutation, it is essential to be counseled, because yes, if a parent is carrying a gene, there is a risk of getting the disease for their children, but not all individual gets the disease. And worrying unnecessary worry is not going to help. It is, of course, leading a healthy lifestyle is very important, but yes, you have a much higher risk than compared to those who are not having their parents this disease, but you are having a higher risk. But it is not that you are 100% going to get this disease in your in when you become adult. So it is not essential to get tested for an unaffected individual for any genetic disease.
Just
And
to
yes, these are the some points I want to say.
Just to add further, as Atanu sir mentioned very rightly, because there are some families for whom we have done genetic testing, and obviously everybody may not develop, but there's always a stress that they may at some point of time develop dementia. So I think those people require a lot of psychosocial intervention, and in our multidisciplinary team, Priya madam does a lot of counseling and work for them. So I think they need a lot of help, but at the same time, we need to take care of them, that they should not be worried too much about their testing, if at all they have tested themselves. So we have such families with us. So yeah.
Yeah. So the next question is also, trying to try and finish the FTD related questions. The next question is related to something that is a practical social problem. So Miss Onu Radha has asked that my husband has been diagnosed with FTD and he is currently unable to perform daily activities. We are filing an insurance claim, but there is no option of putting FTD in the insurance claim. The disease itself is not mentioned. So, can we mention this is a form of Alzheimer's disease for the claim? So, for that, the answer is no. But that actually brings up a very important question. That's a social issue and a policy issue that even dementia and Alzheimer's disease is not covered in many cases. And if even if dementia or Alzheimer's disease is covered, non-Alzheimer's disease dementia are completely outside the purview of our policymakers at this point of time. So, patients who are suffering from the other dementias and their families are facing a lot of issues in navigating different administrative processes, whether that is banking or office, right? So, in FTD patients who is behaving unusually in the office boss or the office itself is unwilling to accept that this is actually some form of brain disorder. So at this point, yes, I don't think insurance will have an option, but I think we should work to that direction, that the non-Alzheimer's dementia as a whole should be an option in at least insurance claims. And now moving on to questions regarding vascular dementia. So as I mentioned, I will club two questions on vascular dementia. One is that I guess there was a detailed case scenario, and the second question on vascular dementia is that my father, who is around 62 years old, has developed vascular dementia after he got a brain stroke. Is vascular dementia fully curable, or how much can we control the loss of memory? So, Atunu sir, if you please kind of go ahead and discuss this issue.
Yes, vascular dementia is a problem of our country. This is not a very common thing in Western countries, because they have achieved a control of vascular risk factor very successfully. But in our country, diabetes, hypertension, and all sort of metabolic risk factors and lifestyle-related factors are playing a role to make us susceptible to develop stroke. sometimes overtly, sometimes very silently. So many patients, they do not get a stroke in their life, but they develop dementia, which we diagnose as vascular dementia because of the microvascular changes that happen in the brain. But as the question goes, whether this vascular dementia behaves differently from what we commonly seen in our clinical practice, the degenerative dementias or the Alzheimer's disease. Yes, they behave differently because vascular dementia is relatively a slow process, and if we can control the risk factor even at any point of time when we diagnose, we can slow the progression and can prevent the further development of stroke, and we can make the patients live a relatively better life compared to a degenerative dementia or what we commonly see in Alzheimer's disease, which is a relatively progressive disease. Once you make a diagnosis, after 1 year, the patient deteriorates. After 2 years, further deteriorates. But in vascular dementia, we can slow down the progression, we can prevent the further development of stroke with modification of the risk factor, control of the blood pressure, controlling the diabetes, controlling the blood lipids, as well as stop smoking and other thing. So this is relatively better as compared to the degenerative dementia. But of course, once the dementia is there, the patients live with some sort of disability. One need to get support from their family and also from the society.
Thank you, sir. And now I'll come back to Dr. Amitabh Ghosh. And this question is related to therapeutic nihilism, which is almost universal for dementia, where sometimes doctors, general physicians particularly, as well as my patients' family members say that this is not going to get cured. So why would I take this medication? Why would what benefit would these medications provide for dementia?
So yes, there are a number of issues here. It is true that as of now we don't have a lot of outstanding drugs for curing dementia. But if I just remember and remind you that we don't have any outstanding drugs to cure liver disease or arthritis or cataract or anything else. So that is kind of human diseases, if you may. What we can do, like all the other diseases, is we can prevent in various ways, and we can reduce the risk of progression. Recently, there has been, so I'll kind of break it up into different parts of the answer. Let me bring the latest one. So recently, there are two wonderful drugs which have been shown to slow down progression of the damage inside the brain. They have shown to remove all the bad proteins called amyloid in the brain, and they have shown to even show clinical improvement. Pretty modest, but pretty significant, and something which has never happened before. So that drugs are not here yet in India, but now we have biosimilars available, and they are kind of officially recognized that you can use biosimilars. So in a couple of years' time, you might have biosimilars available. Number two, research in dementia is going kind of full steam ahead. And if you have and these are all patients who have very early dementia, especially very early Alzheimer's disease. So if you keep yourself in that list where we can call you up and say, this drug is available, would you like to participate? Then it is only then, if you're already there diagnosed as very early memory problem, that you can get called. Otherwise, you will never get called and you will never know. Number three, let me remind you that there are, besides the so-called the Western products, we have for many, many years, thousands of years, we have got Ayurvedic Indian products for you, like Brahmi or Ashwagandha or Shankapushpi. And these drugs have been repeatedly shown to benefit patients with dementia. So I would not say that medicines are not available. They are available. We need to do much stronger and much more controlled research in these drugs in India, which we are still not doing yet. Mostly the Ayurvedic centers have done. A bit of work has been done by AIMS. A bit of work many, many years ago was done by PGI, but we need much more. So that is available. Now, then comes the way how you kind of handle yourself. Once you know that this is an early, let us say, mild cognitive impairment, now control your diet, go back on your exercising, go back on your kind of intellectual activities and everything that Dr. Shinjon told you. You still have some good working networks there, and you need to strengthen them up. Now, what happens if there's a massive hadsa somewhere in Kolkata or Bangalore or Hyderabad or wherever? The major highways are gone. Does everything stop? There's a stun, but then the narrow lanes and the smaller roads, they open up. How do they open up? You clear up the mess. You put directions. This is the way you go. The same thing happens in the brain. Don't forget, brain is a network. And there are many parts of the network which are just sitting silently, which are not damaged yet. So as damage is happening on one part of the brain, you need to activate the other network so that this keeps moving. So that will only happen when you're diagnosed early. So there are many, many advantages of diagnosing dementia early. Those who have even advanced stages, as Dr. Shinjan again told, you can plan, you can what are you going to do about this? So many things. So don't just sit tight at home. You will be the loser then.
So now again, I'll move on to a few different scenarios. The first question is for Dr. Priya. This question is related to social situations. So after I have received the diagnosis that one of my parents has dementia, so should I take them to social occasions, and should I disclose this information to my friends and relatives?
Yes, thank you for that question. Question because this is something that we frequently get as a question from caregivers. How much do we tell others, and how do we communicate to family members, friends? Very often, the behavior changes have already been noticed by those around the around us. In terms of, could be at the workplace, it could be among the friends, it could be among the family members. There would definitely be a discernible change that has necessitated the consultation in the first place. So, to communicate back to the people around us that there is a medical explanation for the behavior change is very important, and we should help the family members to facilitate what to communicate and how much to communicate, and so that the stigma, as we have been talking so much about the social stigma, very often the behavioral changes that has been slowly building up has created a lot of stigma and has created a lot of negativity around the person who is diagnosed with dementia, and that affects the family also. So very often they get socially isolated. They make a conscious decision not to go out because it exposes them to situations that brings out the challenging behavior in the person. So these are all everyday struggles that the families go through, which we need to guide them through how much to communicate. It has to be communicated, and it is absolutely a must that when we work with families, we tell them that instead of isolating themselves, it is possible that we engage with the family, social functions and things like that, but definitely with the support of the primary caregiver, or make sure there are no accidents that worsen their currently already existing fragile self-esteem. It doesn't go down. So we need to have a protective net around them, but so we help the families to do this. That is absolutely must for a good quality of life for the person and the caregiver also. Thank you.
Just to add, Dr. Atri, I think Priya ma'am does a lot of work for a multidisciplinary team. She has a home-based care team, a palliative team, and I mean, the work is too much, but she has been handling it like anything as a part of a multidisciplinary team and doing a great work at same hands. Thank you so much, ma'am, for your answers.
Thank you, Saim.
So the next question is for Ms. Vinita. So this is common for our women patients. So suppose the patient's child comes in and says that my mom has been diagnosed with dementia, and for many years he has been cooking. He has been taking care of all the family meals. But now I'm worried that she is not safe, and it has already happened that once or twice she has forgotten to switch off the gas, and she has burned the food. So what should I do? Should I completely stop? And how do I explain this? And she doesn't want to listen. So how do I manage this scenario?
Yes, sir. It is natural for anybody to resume their normal work, as I told already. So when we stop them from any work that they had been doing, definitely they would be going into frustration, or they would definitely feel lost from that environment. They would not accept that kind of a situation, especially our elderly people will not accept. They will have so many questions. They show anger, temper tantrums. They have a lot of frustration. Behavioral problems do pop up if this is the situation. So what the best we can do, advise as a therapist, is that they can assess what is still feasible and what they are capable of. It can be simple mixing of food or arranging the table, or simple things what they are doing it very well without no concerning the safety. One thing. Second thing is, we can also think of modifying the kitchen in such a way that you label all the sharp tools, like child locker, what we do, child safety. The same way we can do safety precautions for the elderly people, where the sharp objects are not into contact with them, or labeling all the ingredients whatever is there, so that it is easy for them to cook. Or you can also keep pre-prepared ingredients so that they just have to use it. And still more, you are concerned about their safety. You feel that no, they are not capable of offing the gas, as you said, or there is a problem. What we can do is no cooking method, like simple salads. What we wanted to do end of the day is, you have to keep them happy and satisfy them. At the same time, you wanted to make them be active in at home. So simple salads or sandwiches, give them one chance, one time a day for the meal to get prepared by them, so that they also feel happy about it and they are active with the family members. So these kind of strategies can be adopted. And also we have to make sure that we respond to them with sympathy, no sorry empathy. And if they require, there should be a transition phase also, where you can appoint somebody to cook the food, and she monitors or she supervises that particular person, but she'll feel much more happy for that. So these kind of strategies can be adapted for making them be active to cook at home instead of saying no to themselves.
And the next question is related to navigating outdoor environments. So many patients have a habit of taking a morning walk or an evening walk. And now, after the diagnosis of dementia, in many cases, families just stop them from going out. So now they are staying completely indoors, and which is actually a bad thing for them. And then they would ask, how do I keep the patient safe when they are going out for a walk? And so this question is for Ms. Sadia. And I guess there we do have technology available. So right now,
Yes, sir. Thank you so much, sir, for this question. And this is more like to do
so
with.
can you
Sadia,
speak
we're not able to hear you.
Can you hear me now?
Yeah.
Hello.
So possibly
Hello?
you have to speak slightly louder.
Yeah, maybe.
Okay. Um.
Volume is a bit low.
All right.
Yeah,
Yes, now
now it's
it's audible.
becoming better.
Okay. All right.
Yeah.
Great. Yeah. So this is like a very common thing that we come across in our daily, memory clinic discussions with caregivers, where they are very concerned about the patient walking or restlessly walking, and then there is a high possibility that dementia patient would have wandering. So one thing is that it is not much advisable to stop them walking around the house, because that is one way of expressing their discomfort, or we don't know what exactly is going on in their mind, and they want to vent out. This is one way that they try to express. So one thing is that either they are walking inside the house or they are trying to go outside. That can be, both of the situations can be very tricky and risky. So in that way, what we generally suggest is that it can be a supervised walk if it is outside. So, trying to take them, somebody monitoring them, somebody accompanying them, and going to a very reliable place, maybe a garden, somewhere very close by. So, in a very controlled and a safe environment. At the same time, at home, there can be certain safety measures that can be taken care of, like environment modification, as ma'am just mentioned, and then decluttering the house. Generally, our furnitures are, very cluttered in our manner, the way we prefer it to be. But now we need to start looking and observing how the dementia patient is like, navigating through the furniture or through the house. So we can just declutter it, try to get grab bars, or try to see that if they're trying to, hold up to some support, even on the furniture or something, so it's very sturdy. So certain safety measures like that, and giving them that freedom of walking around, trying to, do whatever they want to. The other thing, as just mentioned, that yes, we do have a lot of assistive devices. They all come with pros and cons. So it has to be charged, but then yes, nowadays they are very easily available in the market and online. So GPS trackers or these devices can be used to track, like if the patient is walking outside or something. And then the other thing that we generally suggest is like keeping an iCard on them or keeping the addresses in their pocket. The other thing from my practice, what I have realized that the best solution so far that I have come across is that embroidering the address and the contact details of caregiver on the shirt, on the sleeve, or on the on the sari blouse or so on. And that has really helped because the devices or the iCard is a high possibility that they might lose them or it might not work out. So this is something that has really worked out. So these are certain things, and then trying to take them to very familiar routes or regular routes when they are not very restless. So when they are in a good mood, or when they are in a a very stable state, it is good to accompany them so that there is like a new learning of a familiar route that happens. And in case of a wandering or a restless episode, they try to take up that regular route that was like tried to introduce to them. So these are some tips that will help, but not like to stop them. That may kind of backfire in that situation. Thank you.
So one of my patients improvised this as they used uh, basically Apple AirTag, and they had a particular jacket that the patient, apart from the salwar, the patient wears different salwar, so they have this jacket which the patient puts over the salwar, and on this jacket, in this jacket, the AirTag is sewed in, so they can monitor from home. This is possibly one of the more costlier measures that you can
So it's the
devise.
same thing as embroidery that I'm saying.
Yeah, embroidery is much
Different
more
panels.
available to our patients. But this
Mhm.
actually worked for that particular patient. So now we are going to just pick up the pace of our questions, and I'm going to move slightly quicker. So the next question is to Dr. Priya. This is again related to finances. So once a patient is diagnosed with dementia, what are the financial cautions or the steps that the family should think about?
Yeah, thank you. I will also pick up this pace as you mentioned. Yes, one of the challenges once we identify these changes will be the cognitive changes, will be the difficulties with navigating financial decision making. So with regard to it will be with regard to property, it will be with regard to handling pension, it will be with regard to accessing bank accounts, and sometimes in some forms of dementias, as we already mentioned, it could be also the scams that you have already mentioned, Dr. Atri. So these are all the decision making would be influenced, and that will affect the finances. So it is important that from the beginning, this is also one thing that we wanted to highlight in caregiving, is that from the time of diagnosis, we need not wait for significant changes to happen and accidents to happen. From the time of diagnosis, if we are able to institute a system in which there is some kind of monitoring that is happening, whether the decision making happens together in the family, if the primary caregiver is also having access to whatever is happening with regard to financial management for the patient, this is something that has to be in place from the beginning. It could already so from by the time they reach the diagnosis, they would have probably come to for the consultation itself because of some accidents that would have already happened in the financial area. So in which case the families will be a little more sensitive to it. If not, from the time that the diagnosis is made, we need to also have this conversation that monitoring of financial planning and making sure these kind of decision makings are also taken jointly by the caregiver. These are all some of the instructions that or support that we can suggest for the family. Also, in some cases, power of attorney is a process, and this has several other ramifications because advanced care planning was mentioned by Dr. Sinchan. And so in our country, these are all the discussions that the families will not come to at the early stages. But it is very important that we have these discussions a little early when the person is also in a sound mind, or at least in a position to give their preferences with regard to how do we go ahead and how do we take some decisions and things like that. So these are some of the ways in which we can help to make sure safety in terms of both personal safety as well as financial and property, all those things are taken care of. Thank you.
Thank you, madam. So now we will move on to solutions of some of the more troublesome symptoms of dementia. So the first question is to Ms. Srinitya, is related to dressing. So once the patient develops a difficulty in dressing himself or herself, how to manage this?
Yes, sir. So, first thing, what we'll have to advise is that use simple dressing techniques. Let it not be so much complicated. And once we know that the patient's really struggling with dressing, for example, the front and back or left and right, so there can be a lot of contrast color-coded labels which differentiates from front and back, and some of the ribbons or some of the color codes, as the psychologist was mentioning about different embroidery work also inside the no the collars or the dresses, so that they understand that this is the back of the dress or this is the right, this is the left, the determination to be much more successful. And also use of adaptive clothing like velcros, according to the economical status, if the magnets instead of buttons, or if you say the saris, nowadays the 1 minute ready-made saris are available, which is very easy for them to wear if they wanted to be much into the culture. In the same way, some assistive devices like wrong handle reachers or the button hook holders, these can be advised according to their abilities, the capabilities, and what they're able to do, what they're able not able to do, and all that. And you can guide them. Everything comes with practice. So the more they're going to rehearse every day, little bit of help initially, the caregivers can do the rehearsal every day. That would develop them to be independent in their ADL, as the basic ADL at least. And the routine has to be very simple to complex, then we can grade it. That would be much helpful. So these are some of the techniques for dressings that we would suggest.
So, and now the next symptom that we want to discuss is agitation. This is a very common symptom in dementia, and this is a very difficult symptom for family members to manage. Sometimes patients, family members would prefer, sleeping medication so that the patient sleeps, which is also not a very ideal situation. So I would request Dr. Shinjon to kind of discuss how to manage agitation. What is the current options for the family?
Right. Thank you very much. Basically, as a team, we always prefer to start with non-pharmacological measures, as was mentioned by some of the expert panelists who tirelessly work with patients and their family members. So basically, we try to identify the triggers that upset them. The care plan is individualized according to the patient and what they were like, what their basic personality was like before they developed dementia. So there's no point in arguing. I'll just mention a few points, but there are a host of other measures that we can take apart from just giving medication and making them fall asleep. So basically, not to argue, agree with their condition. There's no point in arguing because they're forgetting what you are saying. They'll keep on asking the same question. And please focus on the positives and not on their shortcomings and deficits, and we can work around it. So then comes the medications, and many a times we see people on a lot of medications that can actually make things worse. So that's when we deprescribe or we reduce medications. So these are some of the features, but definitely we have a lot of options apart from medications. Thank you.
Sir, is it okay if I add up one more thing with this, sir?
you.
So this is where the snoozelen therapy actually plays a good role, I could say, sir. This is where we have seen many patients who has a lot of agitation and frustration when they listen to the soft music with different background of lights and the fountain falling on and the soft music. This is how that agitation also comes down. I had shooted a couple of photos of the patients who literally had a lot of frustration and anger. But eventually, when you are putting them into the therapy area, you can see that the frustration level comes down and they get back to the normal life. And a few of the things that they can do at home also, we had been advising them that they can also create an environment for them, at least 10 minutes of the relaxation to be done. So I just wanted to emphasize here that this therapy is really useful according to me. Like, we have literally seen the patients improvise in terms of anger and the behavior strategies, sir.
Thank you very much.
Just for the caregivers, so this therapy is known as Snoezelen therapy. The spelling is, you can search it up. So spelling is Snoezelen. This is from the Scandinavian method for relaxation, and so you can look it up. So we are nearly at the end of our seminar and so webinar, and so we are going to end with a few more questions. So the next question is for Dr. Amitabh Ghosh, which is related to another troublesome symptom, that is incontinence. So how to manage the patient when he or she becomes incontinent, and very often these patients also have difficulty in wearing diapers.
You're muted, Amitabh sir.
I was saying that maybe Srinitya would be the better person to answer this, but I will try my best. So yes, this is a major issue, people not wanting to wear diapers. I think somewhere the elderly dementia patient relates diapers, probably rightly so, with kids. And all the mess that the diapers do. And the one thing we have to do, and I think it's kind of a learning, is don't discuss diapers, right? Don't say you're using diapers. I think say you're using some shorts or whatever you want to use. Do that. Second, I need to find out. I don't know whether there are adult diapers inside shorts, like you have in children. You have diapers inside shorts for kids. So if you have that, then you officially make the person wear shorts, especially when you're going out, for example, which have diapers inside them, and they're actually wearing shorts, right? So that is one thing. Second, the time, there are various ways of taking the patient for going to the washroom. Time them. I think one good thing is to time. You can either time by trial and error. You recognize that by this time the person is leaking, or you can get a fixed time. But don't force the patient. Please don't pull the patient to the toilet. Just make it very comfortable for the patient. Don't come right in front of the patient, say you have to go. There's one basic thing all caregivers professionally will teach you: be on the side of the patient when you kind of try to get something done for the patient, and then kind of gently hold the patient in the back and talk to the patient, slowly walk them down towards the toilet. Anyway, so time them. So use shorts, don't use the word diapers, time them. And if they don't want to go, and very nicely explain to them, like you explain to kids, like, if you go out, if this leaks, they know what will happen, what will people say. And, it depends on how this person will react with you. But these are the small few tiny tips which I could give, but I'm sure the professional caregivers will give you much, much better than that.
Sir, can I add up one point?
Yes, absolutely. Yeah, we're waiting for you.
There is a cloth which is made by Shahi Exports, which is really there in Bombay. They had developed some of the adaptive clothing for these kind of people. So one such clothing is having an underwear which is leak proof. So, in fact, we wanted to introduce that for our paraplegic and spinal cord injury patients, because they had a problem whenever they do the therapy in terms of functional abilities while rolling and coming up to sit, they leak. So they feel very bad to come for the therapy itself. So we have kept few models of the clothing for these patients so that they have an idea about. And definitely there is available, which is underwears with leak proof. They can purchase it. It is online also there available. So the company's name is Shahi, the Tommy Hilfiger company, who's developing these kind of adaptive strategies. And also, as you said, sir, every 1 hour or 1.5 hours, knowing the patient's urgency to pass urine, we tell them to keep a timed alarm instead of somebody coming and repeatedly forcing them to go. They themselves understand that every 1 hour, 1.5 hours, they have to go with an alarm itself. So this would help them much better, sir.
Thank you. Thank you.
So we have just two more questions left, and in between, I'll just take up one question from the chat box. There is one question related to cognitive fluctuation, where the patient is having significant difference from one day to the next. So the question is whether this is a dementia, symptom of dementia, and my answer is yes. Particularly in dementia Lewy body, cognitive fluctuations are known, where one day the patient may appear nearly normal, and the next day the patient may appear very confused. So yes, so that is a known symptom of dementia. So with that answer, I'll go to the last two questions, which are related to research and future directions. So the first question goes to, the penultimate question goes to Dr. Fahim. So there are some requests regarding research from the chat box as well. So what is the current scenario? Can our patients and their caregivers participate in research related to either Alzheimer's disease or frontotemporal dementia? And what are we looking at for the next 5 years?
Yeah, thanks, Dr. Atri. It's a very important question. And I saw somebody has asked some cognitive neurology subsection for dementia research. I know Dr. Atanu sir will also add, but I don't know who has asked this question. It's an anonymous attendee. Now, I would divide both these questions into two. One would be if it's a healthcare professional, and the other would be if it's a participant or a caregiver or a patient. So the thing is, if it's a healthcare professional, obviously we need collaborations. All of us need to come together, make some consortiums, and then work together if we really want to move forward in the field. So, I mean, that's an academic discussion. We can have that. But as far as this forum is concerned, and today's discussion, as far as the clinical trials are concerned, as Dr. Amitabh sir said, there are drugs approved. There are 3 drugs approved for Alzheimer's dementia. And we often get emails from caregivers and patients, can we use these drugs? Can we get these drugs? The thing is, they're approved in US. They're approved by US FDA. But the research which has gone through these drugs, those trials have recruited only participants from the Western cohort. There's very least representation from the South Asian region in those clinical trials. So we do not know how our patients will behave with those drugs. That's one, which means, should we have clinical trials here in India? Maybe yes, because we don't know how our patients will behave with these drugs. So that is why clinical trials become very important. And I request, and I mean, tell all the caregivers, please be open and flexible for any studies, any intervention studies in India, because any hesitancy from your side, I think that moves the field in dementia backward. And if you're willing to come forward, I think that's the way to move forward and help people with dementia for newer drugs. But that being said, it's not only non-pharmacological. You have to do non-pharmacological interventions as well. Even though pharmacological interventions do come, both of them have to go together, because overall idea is to do a holistic dementia care. So you do both things together, but then do not forget non-pharmacological interventions, because at the end of the day, there's no magic drug for dementia. Drugs may come. These are disease-modifying drugs. As Dr. Amitabh sir nicely mentioned, we will remove those amyloid deposits, amyloid proteins from the brain. But then non-pharmacological management has to go on. It has to continue. And just again reiterating, please feel free and flexible to be a part of the clinical trials, because what I have seen in US, people are willing to, they're forthcoming, they're willing to be a part of trials compared to our Indian participants. They have a bit of a reluctancy or hesitancy. I'm not sure why, but I think it should go off some as the time goes on. And anytime you have any memory issues, as we have discussed in this whole forum in last 1 hour, please seek consultation to your nearest physician, a neurologist. They will definitely be able to help you out in the best possible way, ruling out reversible cause. And if there are intervention studies, we have at NIMHANS some clinical trials which we are doing. And if anybody is willing, you're always welcome to be a part of those if you fulfill the recruitment and inclusion criteria for those trials. Yeah, thank you.
So my comment, just a brief comment, is after one of those drugs were approved in US, so one of the Indian participants who participated in the trial, his interview was published in an US newspaper. And he told the newspaper that everyone around me tried to discourage me that why do you want to be a guinea pig for a new drug? And he went on and participated in the trial. So I think for me, my approach to this is to the patients and caregivers when the doctor is asking you to participate in research, it is a process where the doctors learn from patients. When we see a patients, we also learn from you. But when you are participating in research, we are learning from you in a more structured manner. So you can ask questions regarding what entails participation in research. In many cases, it would be just filling up a few forms. If you want to go ahead with clinical trials, that is also very important, because now that these drugs will come to India, we will not know how they will behave in Indian patients, because there were no Indian participants when these drugs were designed. So that problem will persist unless our patients and our physicians as a community develop our own research studies. So ask as many questions as possible, but ask the questions and participate. And that brings me to the last question of this webinar. It has been an excellent couple of hours of discussion. So the last question is for Dr. Atanu Bishwas. So now that we have hinted that there are new drugs on the horizon, what is the hope from the new drugs and which are in trial or approved for Alzheimer's disease as well as other dementias, so that we can end this session on a note of hope, really?
Thank you very much. Of course, we are in the midst of an epidemic, and this is going to be an epidemic of degenerative diseases, and particularly the Alzheimer's disease and other dementias and Parkinson's and all sorts of diseases. But this is probably the last hurdle we are having to conquer in our healthcare. If we all hope that we'll win someday, then it cannot happen on a single day. So we are progressing, and of the degenerative diseases, Alzheimer's and the amyotrophic lateral sclerosis, the motor neuron disease, these two are diseases where the drugs are approved by the US FDA. US FDA is a very apex body that we always respect, that they only permit those molecules which have a definite benefit shown in the clinical trials. So we got 3 drugs, as Dr. Fahim and Dr. Ghosh has told, that these 3 drugs, these 3 molecules are being approved in the US by the US FDA to be used in Alzheimer's disease. But they are not going to cure the disease at any point of time. They are only helpful to those who are very early stage of the disease, and they give a modest improvement in the clinical improvement, and they remove the amyloid, the bad molecule that are there in the brain. So we hope that in a long run, they will help in improving the cognition of these patients as well, and they will probably live a better life as compared to those who are not receiving. But amyloid is not the only protein that is playing role in Alzheimer's patients or Alzheimer's brain. There are other proteins and other mechanisms of brain damage, like tau, like the inflammation, like vascular pathologies and other things. So it may be so that in future we will have to have multiple drugs combining together, like in cancer. We use multiple agents together to fight a cancer. So maybe in Alzheimer's disease also we'll have a cocktail of therapies that will help the patient to improve their cognition and their behavior and other things. But I am very hopeful that in next 1 decade, we will have a lot of molecule, and Dr. Ghosh has already told that these biosimilars are now in thing, and probably in India, we will have a cheaper version of these drugs. And yes, we have to be ready to use them. So we need more doctors understanding the disease, diagnose them early, and use the available resources which we are having at the moment, or make them available in our country so that we can diagnose them very early, accurately. So that requires a concerted effort from our clinicians and the cognitive neurologist. Cognitive neurology subsection of this academy is doing a wonderful job, particularly those who are youngsters, but I have seen them doing a wonderful job, and they are helping the patients as well as spreading the awareness amongst the doctors, among the neurologists, and also to the caregivers. And we are hopeful that the future of the cognitive neurology or the dementia patients in this country is very bright. With this, I thank all of you for participating. Those who have participated online, those who have observed our discussion, listened to our discussion in this channel or in the YouTube, and those who have put their questions to our panelists, I thank all of you. I also make this opportunity to thank our panelists, particularly Madam Dr. Sangeeta Rawat, who has to rush because of other obligations. She is the president of Indian Academy of Neurology. I thank Dr. Amitabh Ghosh, who is one of the senior most cognitive neurologists in this country, who taught us, all the generation of neurologists in this country, to be a cognitive neurologist. And I thank Dr. Sinjan, Dr. Otri, Dr. Fahim, and of course, the panelist, Dr. Priya Thomas, Satya, and I don't know whether she is online or not. Everyone who has participated in this panel discussion, and also thank the Indian Academy of Neurology, particularly the president and the secretary, to allow us to hold these webinars every 2 months. We will come up with another webinar in January or so, and I hand over this to Dr. Fahim to say a few words, and thanks those who I have missed. Please convey our regards and thanks to them.
Thank you very much, Atanu sir, and thanks Dr. Atri and all the panelists for that wonderful discussion. I would also like to extend my heartfelt gratitude to all who have made this event possible, and my sincere thanks to all the esteemed faculty for sharing your insights and expertise, shedding light on misconceptions surrounding dementia, and equipping our caregivers with practical knowledge of dementia. So, and thanks to all our attendees also, especially our beloved caregivers and patients. We are with them in this journey, and they have to be with us. So nothing for them without them. And so in this journey, they have to be with us so that we can make this whole society dementia friendly. So together we need to take such steps so as to close this awareness gap and break the stigma surrounding dementia. So let's continue this journey with the commitment and compassion. And yeah, thank you very much. And I also wish to thank the IN technical team. They have been a great support for us in this today's webinar. Thank you very much, everyone, and have a great day ahead. Look forward to your participation in the future webinars. Thanks.
Thank you.
Thank you.
Thank you.
Thank you.